Dr. Samir Mehta has joined. We'll go ahead with the next presentation, sir.
Sure, sure.
So Samir, it's early for you and I.
Yeah,
Dr. Sievert is
early,
having
but
Dr.
little
Sievert is having
issues I
afternoon.
had. Yeah,
Dr.
had
Sievert is having
little
afternoon cappuccino, and it's
yeah,
dinner time.
yeah. It's had a little problems connecting. You're able to see now.
Yes.
Look, a pleasure to join you, and sorry if I made your program complicated in any way. Horst, good afternoon. Was a pleasure seeing you in Miami last week. So I'm going to talk briefly about, telemedicine has become far more prevalent, even fashionable in the last 18 months of the pandemic. But this is the work going back to almost 11 years now. And I truly believe that for TCT India and for major centers around India, this provides excellent template to expand this global work. And let's show you this work. So this is the Lumen Foundation. It's been a privilege bringing STEMI education to almost 37 countries now, and mostly trying to help the middle and the low income countries in trying to create STEMI networks and trying to create strategies where they are able to apply both thrombolysis, pharmacoinvasive management, and primary PCI in pragmatic fashion. This is our Latin telemedicine program. It was started in 2011, has required several years to begin. This is what I call the navigational plan. If sites anywhere globally would like to create similar templates, this slide can be downloaded. Otherwise, contact me. We'll send you. The centers were started as a hub and spoke strategy, initially beginning in the town of Barranquilla in Colombia, and gradually expanding to several other sites in Colombia using precisely the same methodology. The navigational slide on the right side, I believe I'll show you even a larger image of it. Here it is. This is Brazil, exactly the same methodology. This is the same protocol used in 382 centers in 4 countries, being navigated by telemedicine centers. Most of the telemedicine centers were located several hundred miles away. 4 telemedicine command centers located in Bogota, Colombia, in Uberlândia, Brazil, in São Paulo, Brazil, and in Santiago, Chile. Falling into 2 groups. The first group was the centers which were located within the country, and this was happening in Brazil and Colombia. But for Mexico and Argentina, the command centers guiding through telemedicine networks were not even located in the country. When we started the program in 2012 in Barranquilla, as I mentioned, it used to take us 21 minutes to make a diagnosis, having several subsets and pathways, how the EKG was initially sent, it was received, the filters were removed, the diagnosis was made immediately, and several alerts were set out, and the entire triage process was started. This time, over about 9 years of work and expansion to 4 countries and involvement of several hundred healthcare professionals, the time has now come down to 3.5 minutes. Exactly the same protocol, hub and spoke strategy, depending on the patient's time to presentation, the distance from the hub. The patient got either thrombolysis, pharmacoinvasive management, or primary PCI. When the Latin program was initially begun in Colombia, 78% of the patients got either no treatment or were being treated with the streptokinase. And the recent data from exactly the same centers are 78% getting door to balloon time within 90 minutes. So this is what I call the navigational pathway for people who are trying to create something similar. It shows you the hub and spokes, how they are located. In this case, this is Brazil, a massive country with its own challenges. One of the most amazing parts about Latin was that there was tremendous regional variation between the four represented countries in Colombia, Brazil, Argentina, and Mexico. In Colombia, it was more of the mountainous terrain and some aspects related to personal safety with intransient terrorism and some other very specific and frightening possibilities. In Brazil, just the immense size of the country was the bigger challenge. Brazil, however, was extremely sophisticated because they've had telemedicine applications in various fields of medicine over the last several years. So this map basically shows you exactly where the spokes were, whether they were small primary health clinics, community centers, their distance from the hub, the kind of an ambulance structure which was existing, whether it was unidirectional, bidirectional, or centralized. Majority of the 382 centers in all the four countries were having bidirectional ambulance, which is possibly the worst possible one to have it. It is also something which I know exists in the majority of centers in India, where there is an alarm, there is an ambulance which goes first from the hub, driving to the spoke, and comes back with the patient back to the hub, going making two terrible pickups in the middle of traffic. The centers are also listed here, the number of patients who were presenting, the number of telemedicine encounters, the number of electrocardiograms, the type of a procedure, if PCI was performed, what kind of method was it? Was it using any thrombectomy or directly stenting? So this is an example of how it was done in Brazil. And exactly, if you take a look at it, the same representative models in the four countries, and providing a network after about 9 years of work of 100 million patients being provided umbrella of STEMI protection. This is the time to telemedicine diagnosis. This is a parameter which we created, which I suggest sites to follow. Of course, door to balloon times, door to needle times, the door in, door out times, all of those we were following. But when you're trying to create telemedicine pathways where millions of patients are going to be treated remotely, the parameter which we created and which we found extremely useful was time to telemedicine diagnosis. Once again, a combination of factors. It involved telemedicine delivery 24 hours a day at the command centers, as well as excellent web pathways. Took many years to create this, but the beauty of this, if you see in the small chart here which has been made, is that time to telemedicine diagnosis was not different whether the center was located in the country or outside. 3.5 minutes in this case, and we've had numerous publications emphasizing precisely the creation and perfection of this model. Here is a more detailed aspect. In this case, about 780,000 telemedicine encounters, the majority coming from Brazil, but spread out across the four countries. Again, the majority were males with the spattering of diabetics, hypertensive, smokers. And I'm happy to state that the majority of the patients were treated with the primary PCI, and exactly what was known and found with the stent initiatives in Europe, that countries gradually have the halo effect and proceed from either no treatment or thrombolysis to primary PCI. This is creating some comparative models as to demonstrate the efficacy of it. The problem with this is that you really cannot have any direct comparison with a behemoth program like Latin telemedicine in 4 countries, 382 centers. The best comparison of something like this came from a center I found here in Iowa, and they had done 9,000 patients as compared to almost 1 million, which we have done. And if you take a look at it, massive tax and healthcare savings which accrue in this particular case, mainly from the avoidance of unnecessary transfers and treatment. We also did economic forecasting, and we realized that the number of patients that can be treated in 2026 could be almost 72,000, bringing in $281 million in financial savings. So not only are you creating an umbrella of STEMI protection, you're also saving lives as well as tremendous healthcare savings. So what exactly is the relevance of Latin? I believe it provides a global platform for AMI management. And I'll also take a moment to talk about the application of this program globally, as well as what we have been able to do with aspects of artificial intelligence. So this is exactly the same program, except applied even to a larger scale in India's most populous state of Rajasthan, with the population of 65 million people and the size of France in population. Exactly the same pathway, except that here cost savings were even larger, and the entire cost of diagnosing a patient is $1 or less. This is combining Latin telemedicine with the nationwide society. This is SOCIME in Mexico. And the reason I emphasize this is all sorts of global partnerships can be created. In India, I have been often talking about it. I had a similar discussion during the CSI NIC meeting last week. And there are all sorts of partnerships which are possible. STEMI India, which does a fantastic job in India, can partner with the various societies there and create pathways. In this particular case, SOCIME provided the educational component, Latin provided the logistics for creating a telemedicine structure. Here is the similar pathway exactly which we are using for stroke. And in this particular example, we have started using some deep learning pathways using both. There are numerous manners how you can impact both the door to balloon time as well as the thrombectomy time for stroke. A final last 2 slides about artificial intelligence. I think we've reached excellent penetration globally with the door to balloon time. We probably will take another 30 seconds. We should be done. This is the symptom to balloon time, which can be impacted by creating a device which the patient is able to diagnose his own STEMI. This is a method how we are able to apply it to various parts of Latin telemedicine. And it is quite possible today that the patient himself with the single lead device is able to diagnose STEMI, and that initiates the process and makes the difference in the final parameter, which is the symptom to balloon time. With this, here are my conclusions that telemedicine offers an excellent possibility in both STEMI and stroke in impacting delivery of STEMI care. Its greatest relevance, I still believe, needs to be or can be in Africa, Middle East, and Southeast Asia. And of course, parts of artificial intelligence, I think, will further impact the symptom to balloon time. Thank you so much, and happy to take any questions and discuss.
Thank you very much. This is really very impressive, Samia. It's kind of your baby, right?
It has taken many years and has not been. I must hasten to add something very important, Horst. See, look at the effort which has gone into creating it. I've become an old man doing this 162 trips in the jungles of Colombia and in very dangerous parts of Brazil. Uh, Despite creating all this, we realized that we were able to treat only 48% of the diagnosed patients. So we've created this behemoth network across an entire continent. You're diagnosing, still we were not able to treat it because of the patient's insurance denials, lack of ICU beds, and of course, unavailability of physicians and some other people. That has always brought to me the real, very sobering reality that unless there is a broad stakeholder participation, in particular by the healthcare economists and the public healthcare policymakers in the country, even programs as beautifully constructed as something like this will only have a limited impact.
That's
So Samir, I have a question. There's so many more ECGs that were sent, and then the diagnosis confirmed. Who is looking at all of these ECGs? Is there a computer screen first or something? I saw 780,000 ECGs in one case, and then I'm thinking about earlier this morning. I wouldn't feel so bad about 48% of people getting treated if you got a phone call like I did this morning about a 92-year-old who has leukemia, is an advanced dementia, and is here with altered mental status and has inferior ST elevation. So I want to take him to the cath lab. Those may not necessarily need to be treated. So at what point does the interventional cardiologist get involved to say, maybe this STEMI doesn't need to be treated?
Right. Exactly right, Dwayne. So what happens here is that the purpose of Latin was to extend and use the power of telemedicine and extend it to the most remote areas. Several of these centers had no physicians. They were manned by a primary healthcare worker or a nurse or something. A patient presents there and they are able to do a EKG. So once you've got millions of EKG and that number has increased far larger, the number of STEMI yield from that is about 1.2%. So our purpose started from that 1.2%. How exactly do you triage? And when the program was started, it was all in every city. It was the same methodology created on a map. Try to understand how exactly do you get the hubs involved, how much was the distance. And of course, like I always tell anybody around the world that the biggest challenge in STEMI management is ambulance structure. It is the logistics of getting the patients, and that was the hardest task. It was in this that we realized that the real virtue came from stakeholder expansion. And in several cities in Colombia, the ambulances were provided by the local supermarket. They provided the funding from the local banks, from various other people to get approvals from the local healthcare administrators. Initially, we were wasting time meeting the mayors and the health secretaries, and realized later that the support came from many other people who understood that this was a program which was going to uplift the care of their own community. Unfortunately, as it is true for the rest of the world, politicians love it, and they will often hijack these programs for their own benefit. And that I often caution people to stay away from that. There is enough power and goodness in saving lives. And once you broaden your stakeholder support, which is, as we learned these tricks, this came in extremely handy in Brazil, parts of Argentina and Mexico.
I feel bad to interrupt the discussions. I mean, this was really very impressive, very great, but we are running behind 30 minutes. And so I think we have to move to the next presentation. Samir, many thanks again. And,
thank you so much. And I apologize, Horst, if my tardiness complicated. I sincerely apologize. There were some issues connecting, and thank you so much for a wonderful session.
Thank you very much again. So are we moving on to the next session then? Dr. Sundaram is there.
Yes, sir. We will move on to next session, sir. I would like to thank you, Dr. Dian Pinto and Dr. Samir Mehta. And